Hi, my name is Gretchen Delametter. I'm a pediatric nurse practitioner with UNC Neurosurgery here in Chapel Hill, North Carolina. I'll be talking to you today about Chiari Malformation, Syringomyelia, and asking you to consider Chiari with your workups. Our team at UNC consists of Dr. Scott Elton, who you'll meet later today. He's our pediatric neurosurgeon, and Melody Wattrell, the other nurse practitioner that works here at UNC in the Department of Pediatric Neurosurgery. We do a number of things here at UNC, Chiari Malformation being one of them. You can check our website, UNC Department of Neurosurgery, to see all the wonderful things that we're accomplishing here today. Our objectives today are to briefly discuss the history of the definition of Chiari malformation, identify the types of malformations, and we'll specifically focus on Chiari 1 malformation as it is the most common seen in your offices, review the workup and diagnostic studies that are done prior to the diagnosis, and then what we do once the diagnosis is made and you make the referral to neurosurgery. We'll discuss the referrals and the subspecialists that see patients with Chiari malformation. We'll identify, evaluate treatment options, determine the follow-up needs, timing, and specialty, and provide, of course, parental support, as this can be a long, drawn-out process for them. So briefly, the history of Chiari malformation. This is Dr. Cleland. This is Dr. Arnold, and this is Dr. Cary. And we go back into the late 1800s when this was first noted in pathology post-mortem, this cerebellar herniation through the foramen magnum. First noted by Dr. Cleland in 1883, and he called it basilar impression syndrome. And then Dr. Cary and Dr. Arnold, which are much more used to hearing their names. So there's a long history of trying to deal with what this abnormality is. And to briefly discuss this abnormality, Chiari malformation is the structural defect of the cerebellar tonsils herniating through the foramen magnum down into the upper part of the spinal cord. This is just a drawing or a cartoon drawing of this, and this is an actual MRI of one of our patients. The yellow line here denotes the opening of the foramen magnum. You can see the cerebellar tonsils here as it is here, herniating or protruding down through the foramen magnum. And then a syrinx is a cystic or fluid cavitation within the parenchymal of the spinal cord, with hydromyelia is a dilatation of the central canal. Oftentimes now with the remarkable imaging that we have on MRI, we can see what is a normal variant of a dilated central canal, and that would be a hydromyelia or dilated central canal. So there's multiple types of Chiari malformation. Type 1 is the most common seen, and here's again a picture of the type 1. This would be normal cerebellum and the position of the tonsils. Type 1 is where the cerebellar tonsils protrude, herniate, or go through the foramen magnum. It does not involve the brain stem. It generally is there at birth. However, it can never be picked up. It can be incidentally picked up for workups for other reasons, or it can cause a lot of problems, which we're going to talk more about today. Chiari 1.5 was first found or described in the mid-1990s, described in the literature, and this is the cerebellar herniation and with also brainstem herniation down through the foramen magnum. Chiari type 2 is the Chiari malformation that is associated solely with open neural tube or closed neural tube defects. So the patients that have what we all know as spina bifida or occipital encephaloceles will generally have a Chiari 2 malformation. Other types of Chiari malformations are type 3 and type 4. This is a picture of type 3 where the cerebellum and the brainstem protrude through the foramen magnum along with the fourth ventricle out at the cervical occipital region. This is rare, it's the most serious, and often is the most morbid. Type 4, very rare, but that's where we have cerebellar hypoplasia. And recently also has been discussed type 0, where the patient has all the symptoms of a Chiari malformation, but there is no cerebellar tonsillar herniation. However, they may have issues along their spinal cord with the syrinx, and they may progress down the same path for treatment as the other Chiari malformations. So Chiaris are found, they're below the foramen magnum in adults, greater than 5 millimeters unilaterally. Now remember, the cerebellar tonsils, if we think of this in a 3D format, there's tonsils on both sides, so you could have a unilateral herniation on one side, and that would be anywhere from 3 to 5 millimeters. Herniation would be considered a cerebellar tonsillar herniation and associated with a Chiari. There aren't good measurements in children, as depending on the age, that would depend on how long their cervical, the foramen magnum goes through onto their cervical spine, and their foramen magnum opening is different depending on their age. So they could have a much less herniation but be symptomatic because of their foramen magnum opening being smaller for multiple reasons. So first it was reported by myelograph studies in 1940s. 1973 myelograms identified them. 1985 there was a measurement when MRIs came out, they started measuring, and that's when these measurements came into play. In 1992 they discovered that some of the patients that were identified with cerebellar tonsillar herniation had it went away on further imaging, so it ascended and went away. So that was first documented in the literature. 1998 they started talking about Chiari 0, and then in 2004, very recently, Chiari 1.5. Now that's again associated with the Chiari malformation, where the cerebellar tonsils herniate through the foramen magnum, and then it's also associated with brainstem herniation. Now the Chiari 2 malformations that are associated with spina bifida, they can have brainstem herniation. There's not a Chiari 2.5, but the Chiari 2s can range from a minimal to very severe with brainstem kinking and herniation through the foramen magnum. So what are some of the associated findings with Chiaris? Parents always want to know, does my child have a genetic disorder? Is this a family trait? Do they have something else wrong with them? And the answer is, or could this have just occurred spontaneously? And the answer is yes to all of those questions. They have found that there are some common genetic disorders, chromosomal abnormalities, syndromes that can be associated with a higher likelihood of having a Chiari malformation. So they're listed here. So if you have a child that you are working with, that you have, let's say, hyperreflex, they're very flexible in their extremities and can bend their hands back, and their joints are very flexible, and they tend to have a lot of scar tissue, you might want to think of sending them to genetics to work up Ehlers-Danlos, and that can be associated with Chiari. So there are some things that you will be following and sending referrals to, in addition to neurosurgery, but to genetics and neurologists, and they can have quite a lot of subspecialists in their life. Craniosynostosis, that can be incidental finding, it can be associated with a Chiari malformation, tends to be associated because of high intracranial pressure associated with the synostosis pushing down on the cerebellar tonsils. Not always, but generally when they have pansynostosis, so all of the cranial sutures are fused, the pressure can cause the Chiari malformation. The characteristics that are found with a Chiari 2 malformation that we look for in our spina bifida population are specific. There's a beaking of the tectum. There's an absence generally of the septum pellucidum between the lateral ventricles. There's poor myelination of the cerebellum. Generally there's hydrocephalus. If not prenatally, then there's hydrocephalus once the neural tube defect is closed. Generally there's hypoplasia of the falx, microgyria, degeneration of the lower cranial nerve nuclei, and that's very important. Often the thought is that the herniation of the cerebellum create pressure on the brainstem, and this is what's causing lower cranial nerve problems like swallowing and breathing. However, with spina bifida being a neural tube defect problem, those cranial nerves may not have developed normally to begin with. So sometimes it's appropriate to do surgery to decompress the Chiari 2, but other times it's not going to matter, and there is risk always with surgery. And so the neurosurgery team works with the other subspecialists to carefully determine which baby or child should receive the decompression surgery, weighing the risks and the benefits in the spina bifida population. There's bony abnormalities and again hydromyelia as well. So this is a very busy slide. In no way do I think that you're going to be able to read all of these, and I don't want you to. That's a whole hour in itself talk. This is straight from the National Institute of Neurological Disorders and Stroke from the NIH, so you can go to their webpage. But what I do want you to know is that there are many, many, many symptoms that have been associated with Chiari malformation. Now, they have the symptoms, and they may or may not have a Chiari malformation, and they may have a Chiari malformation with these symptoms, but it may not be the Chiari that's causing these symptoms. Research is still ongoing in that arena, but there are many symptoms. Let me just read a few for you. Headache certainly is our number one. Neck and shoulder pain, ringing or buzzing in the ears, dizziness, facial pain and numbness, hoarseness, snoring, difficulty swallowing thin liquids or chewing and swallowing foods. On down, you may have changes. You may see changes in your clients in their reflexes. They may have pain in their lower extremities. They may drop a lot of things. Now, if you're looking at a toddler, this is what a toddler does. They can be cranky. They can vomit sometimes. They can make noisy sounds because some of them are in daycare and exposed to a lot of upper respiratory problems. So it can be quite a detective game or challenge in working up these patients before you get them in the MRI scanner and determine that they have a Chiari. The infants are very challenging when we're trying to determine if they have a Chiari malformation, mostly for you in the primary care arena, as infants can tend to be irritable and inconsolable at times. They can have problems with feeding and you have to change formulas. They can have problems with swallowing and choking, but when these are persistent and they have poor weight gain and they have excessive drooling and a weak cry, gagging and vomiting all the time, you start noticing that they're not using their hands or reaching for objects as they begin to grow. We want you to consider that they may have a Chiari malformation that may be playing a role in their symptoms. So what is the workup that's done before they see neurosurgery or before it's determined that they have a Chiari malformation? It can be very comprehensive. Just as we talked about the infants, it may be months before it's found that they have a Chiari malformation. So they may have been through quite a few different formulas, GI specialists, maybe they've been to pulmonary specialists. If they were born a little early, they may have a little bit of aspiration problems, so they might have some breathing problems. They've generally had swallow studies and sleep studies because they're noisy breathing, or they might have some apneic episodes while they're breathing. They may have had x-rays and CT scans, and then an MRI is generally the last thing that's done, and then the Chiari is found and they're referred to neurosurgery. So there are a lot of specialists that can be involved in this along the way. And again, what we want you to do is when you have a persistent problem that meets this criteria, to consider Chiari as one of your differentials. So what are the top symptoms that we see? We see headaches, nausea, vomiting, and irritability, and just a general, they don't feel good. When they have cerebellar involvement, they're going to have apnea, bradycardia, problems with strength in their upper and lower extremities, problems with their reflexes. They might even have spastic or odd movements of their extremities, problems swallowing and eating. They might have a hearing loss. That may be how the workup starts. They may have some ataxia or abnormal gait. They may have problems with their lower extremities. Kids have described this as a prickly feeling or tingling or sparkles. We have one little girl that calls it sparkles in her lower extremities, and that's their interpretation of how it feels. They can have paresthesis and weakness. Scoliosis can be associated. Generally, that's in the older child or young adult when that's found. Very rarely, but they can have seizures and developmental delays that they may have an underlying brain abnormality along with their Chiari malformation. So the most common is type 1, and we're going to go through each one of these types, but we're really going to focus on type 1. They generally have occipital and upper cervical headaches. So when you talk to a child and he's saying he's having headaches every day, if he goes like this on his forehead, it's probably not a Chiari headache. However, you do need to investigate, does the headache start back here, but this is where it ends up, and so that's what they remember. And oftentimes when we do a little bit more investigation of their headaches, they do start in the back of their neck and they move forward and end up here, and it becomes a global headache. They can have neck pain only. They can have a combination of all of these signs or symptoms and presentation, or they can have nothing and it's found incidentally. So again, the sensory changes, ataxia, persistent crying, and irritability in the infant. And again, it can be an incidental finding and only on imaging, and they have no symptoms. You still need to refer them for a neurosurgical opinion, and then we would most likely get further imaging along their entire spine with an MRI to assess for any problems with the fluid collection in the spine as syrinx. So these are some more of the problems that can be associated, or symptoms that can be associated with Chiari malformation, GI abnormalities, bowel and bladder abnormalities, postural orthostatic tachycardia syndrome, syncopal episodes, anxiety, depression, because the child, as they get older, don't know why they keep having headaches, don't know why they can't concentrate at school. They're a smart kid, but there's just times where they have no concentration at all and they can be very frustrated. So the physical exam findings, you can have 100% normal neurologic exam where absolutely nothing is abnormal. And generally that's what we find. And then we have some other symptoms here that can be found. You just need to be very comfortable with a very detailed neurological examination and document the things you find. You don't want to lead the child on and saying, suggesting things, because depending on how bad they feel, they may agree with you that they have this symptom and they don't, but they want whatever symptom they do have to be taken care of. And so you want to be very careful in your neurologic exam, your very detailed neurological exam, to not lead them on. So I'd like to now entertain any questions. If there aren't any questions, we're going to move on and look specifically at an example of each one of the types that we have talked about. And we'll start with type 1. So what we have is, remember, type 1 is the most common. It's the cerebellar tonsillar herniation through the foramen magnum that does not include herniation of the brainstem through the foramen magnum. It's not associated with spina bifida. So we have a 12-month-old who presented with a big head, and we all need to be very thankful for all those pediatricians and men and women 60 years ago who made sure by hand, calculating those growth charts, thousands and thousands and thousands of data points that they did by hand to create those growth charts that we all use every single day for our patient population. And so we're talking about the head circumference growth chart when we talk about macrocephaly. And as the child's head grows larger than it should over the period of time, there may be a concern, and the imaging may have been a CT scan to start with, and it's a little hard to see a Chiari malformation on CT scan for the untrained person. We do look through the foramen magnum on the CT scan, but we do prefer an MRI. So we have a 12-month-old who was meeting all of his developmental milestones timely, but he had, because of his macrocephaly, an MRI was done, and he was found to have a 6-millimeter herniation of his cerebellar tonsils below the foramen magnum and a spinal syrinx. He developed, here's his herniation through the foramen magnum, would be right here. Here is the spinal syrinx. It's a very large spinal syrinx. He had headaches and low back pain, but as a 12-month-old, that's hard to interpret. He was doing some head banging. Children can have behavior developmental issues and head bang, but oftentimes we see that in their history that they've been head bangers and they've been doing it for pain in their head. He had started to walk and then had a decline in his ability to walk, where he was falling all of the time. So because of the herniation in the syrinx, we did know that there was an obstruction in the cerebral spinal fluid flow, and because he also had enlarged ventricles, he initially underwent, let me tell you this first. So he had a syrinx that went below the cords. Sorry, we'll back up. So he underwent a ventriculoperitoneal shunt. We needed to divert the cerebral spinal fluid from his ventricles and relieve the pressure that was above the Chiari malformation, and then follow this along in hopes that by diverting the backed up fluid, we've diverted fluid to not build up into the spinal cord. When that is safely done and we're through our postoperative phase of the ventriculoperitoneal shunt placement, then we can, if we feel we need to, progress with a Chiari decompression or occipital cervical laminectomy, occipital decompression with cervical laminectomy, and then opening of the dura and patching the dura to provide room for the cerebral spinal fluid to regain its normal flow pattern. And again, here's the picture of the syrinx that came all the way down into the upper thoracic spine. So he did well with his ventriculoperitoneal shunt. His syrinx began to resolve without posterior fossa decompression, but he is still followed in our clinic today. So our case 2 is a type 1.5. Remember, this is the cerebellar tonsillar herniation with associated brainstem herniation through the foramen magnum. and it is not associated with any other CNS or central nervous system abnormalities. And so in this MRI, you can see the cerebellar tonsil herniation here and the kinking in the progression of the brainstem here down through the foramen magnum, which would be at this line here. So he was first found to have his Chiari malformation. He was being worked up for some hearing loss, and the otolaryngology department here at UNC obtained an MRI to look at his 8th cranial nerve, and that's when they found the Chiari malformation and referred him to us. He did not have headaches, he did not have problems eating, he did not have any problems with ataxia. He was just a very sweet 6-year-old that was having some hearing problems. He underwent surgical decompression, had a small syrinx that you can see here. He had to return to the operating room because he developed adhesions in scar tissue that created a problem with cerebrospinal fluid flow, and so he had to go back and have further surgery done. After his second surgery, he did well. He continues to have his sensorineural hearing loss. He is completely asymptomatic still, and we follow him closely. You can see his syrinx has reduced in size. He gets follow-up scans now annually or sooner as needed. So our case number 3 is a Chiari type 2, and remember the Chiari type 2 malformations are always associated with neural tube defects like spina bifida. So our little patient was born in 2010. We're going to take you through her first month of life. So she was born in 2010. She had open neural tube defect. It was closed on day of life 1. MM is myelomeningocele. Sometimes you'll see MMM. You'll see ONTD, open neural tube defect. She did develop hydrocephalus and required a ventricular peritoneal shunt on day of life 9. She was intubated for both surgeries as a newborn, and she did well with intubation and extubation with no problems noted with the anesthesia team. She tolerated her feeds without difficulty, and she was able to be discharged home on day of life 13 with follow-up set up for day of life 22, which is the typical hospitalization, and then follow-up is very closely after hospitalization to look at the incisions to see how the babies are doing, take their stitches out if it's required and the absorbable stitches weren't working. Get babies with, remember, with myelomeningocele or spina bifida also have problems with bowel and bladder elimination. They have problems with movement below the level of the defect. So orthopedics is involved, pediatric orthopedics. Pediatric urology is integral in their care, and pediatric physical medicine and rehab. So she had come back for her multiple appointments on day of life 22, and her neurosurgery appointment was the last appointment of the day. And when we walked into her room, she was having extreme difficulty breathing with supraclavicular and suprasternal retractions that were just very impressive. She was using all of her accessory muscles for breathing. The grandmother and the mother looked very calm in the room, and so trying to get the baby in a position where we could change her head to try to open her airway a little bit more. We did finally find a position where she wasn't making quite so much noise. And the mother said shortly after they went home, she started making noise breathing and started having problems feeding, and she was just doing okay. It hadn't gotten as bad as it got on the day we had seen her until about a day before. And they knew they were going to be seeing everyone on their hospital visit for their big long day on this day, and so they waited to see everyone. We admitted her directly to the hospital because she was in extremis with her Chiari 2 malformation as well as her lower cranial nerves. She underwent a Chiari decompression emergently to try to relieve the pressure on those lower cranial nerves. And over time, however, let me go back. So we also got spinal imaging. You can see her Chiari decompression. Her brain stem has come all the way down and is kinking very low into her cervical spine. And then she has a very significant syrinx. And so the decompression, we did make sure first that her ventriculoperitoneal shunt was functioning properly, and it was. And we did the Chiari decompression. You can see shortly after we got another image and the spinal syrinx was reducing, which is appropriate. We opened up the area back here so that she had more room. We don't cure the Chiari. It's kind of like with hydrocephalus. When you put in a ventriculoperitoneal shunt, you haven't miraculously cured hydrocephalus. You've diverted cerebral spinal fluid. They still have hydrocephalus. So she still has a pretty extensive Chiari 2 malformation with brainstem and cerebellar herniation. We've just made more space in the back of her skull and in the back area of her brain for the cerebral spinal fluid to flow in its more usual pattern. Now, because the children with spina bifida also have cranial nerve development abnormalities, she did go on to require a tracheostomy and a G-tube, and that does occur in these patients that have this spina bifida with this very extreme type of Chiari 2 malformation. Let me tell you a little bit about something that we do here at UNC. We're very proud of this. We offer fetal surgery on fetuses between the gestational age of 22 and 26 weeks gestation. We can go as early as 19 weeks, but we prefer 22 weeks for surgery because their skin is a little bit older at 22 weeks, but we offer fetal surgery along with our maternal fetal medicine experts, where we close the neural tube defect on the fetus and then close the uterus back and then have them deliver sometime between 32 and 37 weeks gestation. What we have found, the NIH had a long study that found it, by doing this fetal surgery, it reduces the amount of the number of children who need ventriculoperitoneal shunts by as much as 30 to 40% from the postnatal closures. What we've found is that one of the things it does is, while these fetuses then continue to develop and their cerebral spinal fluid stays in their brain instead of on the back of their neural tube defect sac, their brain and skull growth is able to grow bigger, and it opens up their area back here that generally remained very small, and we felt like contributed to the Chiari malformations. So this MRI is of a fetus with a neural tube defect with a Chiari malformation. It's part of the criteria to be considered for fetal surgery, is we do have to have the Chiari malformation. This is the same baby. He's a little over a year old, and you can see in imaging his Chiari malformation ascended from the time he had fetal surgery until he was a year old. He did, however, require placement of a ventriculoperitoneal shunt, but he had very slow development of his hydrocephalus over 14 months, and he was 14 months old before he required that. Case 4 is a child who's not an infant now, but he was born with type 3 Chiari malformation, which is a meningoencephalocele in the occipital cervical region. Generally, this is very rare and it yields a very high morbidity and mortality. This young man has done very well. He is a teenager in high school. He does have some delays. He did develop hydrocephalus, and he has a ventriculoperitoneal shunt that he's required surgery over the years on for revisions. But he has done very well. This is a CT scan where we have that opening in the foramen magnum where it's very open and you can see brain herniation through there. But generally, this is a very optimistic case for the type 3s. Generally, this does yield a very high morbidity and mortality. Type 5 we're going to talk about is the Chiari 0. Remember, this was first described in the literature in the 90s and seems to be associated with all of those other symptoms besides headaches, nausea, dizziness. So they can have chronic constipation. This particular child at 5 years of age was always having problems with chronic constipation and urinary abnormalities. And he had urodynamics that showed neurogenic dysfunction between the bladder and the bladder neck. He had had multiple hospitalizations for his bowel cleanouts. And they did an MRI on his abdomen and saw a syrinx, so they referred him to us, and we further imaged his brain and his entire spine. And you can see the foramen magnum here, and you see those cerebellar tonsils are above the foramen magnum, so he does not have a Chiari malformation in the defined sense prior to type 0. However, you can see down here in the lower part, this is the lumbar region of his back, and here's the tip of his spinal cord, and you can see that this syrinx comes very low, and then this is a different angle, but coming up through the thoracic and the cervical, and you can see the syrinx all the way up. And so we decided to do a posterior fossa decompression for him. He had new episodes of back pain and leg pain, intermittent headaches. He continues to have problems with bowel and bladder and went to the specialists at Cincinnati Children's and he was found to have some GI motility abnormalities. He has since recovered from his extensive Chiari malformation and surgery, and we do follow him in the clinic annually. So if there aren't any questions, I'd like to talk to you about what we know, what we've just talked about. So the common features are impaired CSF circulation. And a lot of times the families come to us and the children come to us and they just want their headaches fixed. And we don't guarantee that we can fix their headaches. Their headaches may be caused by the impaired CSF circulation, but it may not. They may have headaches with their Chiari malformation, but they may also have other types of headaches. Our goal for surgery is to create a normal cerebral spinal fluid flow, as normal as we can for these children, to try to prevent further complications associated with their syrinx or their Syringomyelia, and to return CSF back to its normal flow. That is our goal for surgery. If the headaches improve, we're always very happy, but we do use our colleagues in the pediatric neurology department to help with headache management for these children. What we'd like you to do is consider Chiari when you're doing your workups for your patients with unusual problems that are persisting. So they may not have headaches, but they may have a Chiari. Now I'd like to introduce you to Dr. Scott Elton and Melody Wattrell, pediatric nurse practitioner, that complete the team here at UNC for pediatric neurosurgery.
So thank you, Gretchen. As you've heard from Gretchen, we have a lot of expertise here at UNC. In the 13 years that I've been in practice, I've learned certainly that most people with Chiari don't need surgical treatment, but when they do, we certainly are more than capable of providing all of that care. We take care of children from newborn up through age 18, and take care of Chiari in all of those ages. Again, thankfully, most don't need surgery, but you're in good hands if you come to UNC. We can certainly provide that care. As you can see, it's very much a team approach to taking care of these children.